Good evening, ladies and gentlemen. Welcome back after the much needed coffee break. I welcome you all to the this evening's industrial talk, which will be delivered by Dr. Rahil Iftikhar, and he would be discussing the DLBCL management with innovative therapies. So, I would like to call upon Dr. Rahil Iftikhar from PBMT.
Bismillah ar-Rahman ar-Rahim. I will welcome everyone in this Roche sponsored symposium, and the topic is diffuse large B cell lymphoma management with innovative therapies. So, I have been engaged by Roche as a speaker, and there is no other financial relationship with Roche. If you look at diffuse large B cell lymphoma, it is the commonest non-Hodgkin lymphoma among all low-grade and high-grade non-Hodgkin lymphomas, and it constitutes around 1/3 of all the NHLs. If you look at patient journey, how the patient moves once the patient has an initial diagnosis. So if you do not treat a patient of diffuse large B-cell lymphoma at diagnosis, the median overall survival is around 15.8 months. That is by not treating means, by not treating as per standard of care protocols. Once you treat them with first line R-CHOP or another novel regimen, we are able to cure around 60% of patients. However, around 40% of the patients will have relapse refractory disease and will be requiring second line or third line treatment. The second line treatment is evolving continuously, and currently there is no standard of care third line treatment. And once we are looking at third line treatment of diffuse large B cell lymphoma, the median overall survival is only 7.7 months. We know about a lot of factors which affect prognosis. IPI score is historically being considered as one of the score that all the physicians apply in their clinic to prognosticate their patient at diagnosis. And it has shown to be of significant prognostic impact. But there are other factors that also need to be considered once we are looking at outcome of our DLBCL patients. Comorbids is one of them. Cell of origin. So we'll talk about that. And whether it is a diffuse large B cell lymphoma or it is a double hit or triple hit lymphoma. So at diagnosis, once in clinic, we receive any patient of diffuse large B cell lymphoma. Now it is mandatory to exclude presence of c-MYC high-grade B cell lymphoma because the treatment upfront, the treatment plan, the prognosis, everything actually changes. So the standard guidelines of looking at Chi-67 to guide whether we should screen for these patients no longer holds true. So all the patients of diffuse large B-cell lymphoma must be screened at diagnosis. So we had actually our CHOP approval in 2000s. And after that, for 20 years, there were a large number of trials which were conducted that we will see that actually failed to beat R-CHOP. And R-CHOP remained the standard of care. Till in 2020s, there were different novel agents that were approved. And over last 5 years, now we have got a plethora of agents that are either approved or under consideration for approval in upfront, in second line, or in third line settings. So how we optimize first line treatment of diffuse large B-cell lymphoma? As discussed, for 20 years, R-CHOP remained the standard of care for diffuse large B-cell lymphoma. And the difference was by addition of rituximab. So if we compare the outcomes of CHOP versus R-CHOP, so the 5-year PFS was 30% versus 54% for R-CHOP. So R-CHOP became the standard of care and remained so for next 2 decades. So The clinical practice over next 2 decades actually hovered around R-CHOP with different modifications and different interventions to reduce toxicity or to improve efficacy. And to reduce toxicity, FLIER study actually looked at early stage diffuse large B-cell lymphoma patients who had a low IPI score and randomized them to receive either 6 cycles of R-CHOP or 4 cycles of R-CHOP followed by 2 cycles of rituximab, and looked at cumulative incidence of relapse, which was similar between 2 arms. The same was progression-free survival between 2 arms. So on the basis of FLIER study, the recommendations came out that if you have got an early stage diffuse large B-cell lymphoma with low IPI, you can reduce exposure of conventional chemotherapy from 6 cycles to 4 cycles. And in the last 2 cycles, you can only give rituximab alone. However, if we look deep into the data of outcomes of R-CHOP, so the overall progression-free survival is 54%. But once we looked at the factors affecting prognosis and we saw that cell of origin is one of them. So if we looked at the outcomes of germinal center B cell type versus non-GCB type, the outcomes are significantly different. So if you look at progression-free survival of non-GCB type, the 24 months PFS is only 28%. And the overall survival for non-GCB type is only 46%. So once you have non-GCB type as cell of origin, the PFS is significantly low. So this is a subgroup that we need to take into consideration once we are treating our patient and once we are counseling them about their prognosis in diffuse large B-cell lymphoma. So with R-CHOP, the 5-year PFS of 54% does not stand true for everyone, regardless of their cell of origin, and if you have not looked at whether the patient is c-MYC mutated or not. So once R-CHOP was approved and became standard of care, over next 2 decades, there were a number of trials which were carried out in order to improve upon R-CHOP. These include enhancing anti-CD20 antibodies with the help of obinutuzumab. So R-CHOP was changed with G-CHOP or O-CHOP. It was by addition of targeted agent like lenalidomide, bortezomib, ibrutinib, bevacizumab, and all of them were negative trials. Then there was a thought that if there is increased risk of relapse, you may add on some maintenance therapy to reduce the risk of relapse. And all the efforts to reduce maintenance were actually again negative trials. These included addition of lenalidomide, everolimus, rituximab. So there was no benefit of R-CHOP maintenance. Then there was intensification of conventional chemotherapy, that you can intensify conventional chemotherapy upfront, maybe give dose-dense R-CHOP, or give dose-adjusted EPOCH at upfront, or give hypersev at upfront in order to improve progression-free survival. But all these trials, if you look at this, at that time, all the available options were actually looked at, but all of them were negative trials. So the only positive trial that came in early 2020 was by addition of polatuzumab vedotin with RCHP. So basically, the vincristine was replaced by anti-CD79B polatuzumab vedotin, which is an antibody drug conjugate. And just like brentuximab vedotin, it has got MMAE domain, which actually goes into the cell, causes cell lysis. So the POLARX trial was a phase 3 trial that randomized around 879 previously untreated patients, age 18 to 80 years, with IPI score of 2 to 5 and a ECOG PS of 0 to 2. So with respect to age and IPI score, it was a diverse subgroup, but all of them were clinically very good, as you expect in all these clinical trials. And the patients were randomized to receive POLA RCHP versus POLA R-CHOP. And interestingly, they gave 2 cycles of maintenance in both arms, which is not the standard of care otherwise. And the primary endpoint was progression-free survival, as we expect in all the clinical trials these days. And secondary endpoint was EFS, PET negativity, DFS, OS, and safety. So if you look at these trials, the Polar RCHP, there was no difference between overall survival between the two arms. But progression-free survival was significantly better in patients who received Polar RCHP. If you look at perspective from a low middle income country, we see that the 2-year PFS was only 6.5% between two arms, which does not seem to be a very great difference. However, if you look at hazard ratio, it was 0.73. So in this arm, there was 27% reduction in risk of progression, relapse, or death, which actually led to approval of Polar RCHP as first-line treatment along with R-CHOP in diffuse large B-cell lymphoma. We may not see the impact to be great or large, but at least it started the era that at least there is one drug which has shown to improve progression-free survival. Again, if our patients are paying out of pocket, this 6.5% or you translate into 27% risk reduction may not balance the financial toxicity that this upfront Polar RCHP will incur with respect to the benefit that is gained. However, can we further select our patient and risk stratify that which patients in our setup we can choose who may receive Polar RCHP? So can we have a little quiz again? So if you just write at your mobile slido.com and you'll see this code and you can attempt that. Is there any further subgroup which are associated with significantly better PFS in Polar RCHP arm? So these are 4 subgroups. So dark zone signature is on the basis of gene expression profile. You can take dark zone signature as alternative to double hit or triple hit subtype. Then activated B cell subtype, which is a non-GCB type. Then GCB subtype or DLBCL unclassifiable. So we'll wait for a few seconds so that if we can receive few more answers. So 82% of the participants have voted for ABC subtype, and there are no votes for DLBCL unclassifiable or dark zone signatures. So just a quick view of what is the prognostic importance of different genetic markers. So as per genetic classification of diffuse large B-cell lymphoma, we classify it into GCB, ABC, and unclassifiable. So we'll skip all these classification which are NGS based, which have divided DLBCL into different genetic clusters, and they have looked at that each genetic cluster is prevalent in a certain subtype. But what we will focus is that patients with germinal center B cell type continue to have a favorable prognosis unless they are MEK mutated or they are high grade B cell lymphoma. So GCB type otherwise has a good prognosis unless they have a double hit or triple hit phenotype, and the prognosis of activated B cell type continues to be poor. But in our practice, once we do not have access to gene expression profile, what we can resort to is Hans or Telly algorithm. So Hans and Telly algorithm are now universally applied even in Pakistan in all the good labs who actually histopathologically classify diffuse large B-cell lymphoma. For junior colleagues, once you will get an initial report of diffuse large B-cell lymphoma, it is on limited immunohistochemistry, and the lab always has a note written down that additional immunohistochemistry can be requested if required. So you must request for additional immunohistochemistry in all the patients of diffuse large B-cell lymphoma to subtype that upfront and apply Hans algorithm in your clinic. It will not take more than 30 seconds to subclassify your patients into GCB or non-GCB type. It may not be 100% reflector of gene expression profile, but there is enough data to support that it is an adequate surrogate marker to differentiate into GCB and non-GCB type. And as expected, as we have discussed, the prognosis of GCB type is better as compared to non-GCB type. So if we look at PolarX subgroup analysis, so as we have talked that our patients may not be affording, and as a clinician in Pakistan, we may not be very inclined to advise them polatuzumab upfront, but there are few subgroups which we may consider upfront, and if allowed, that PolarX should be considered, in which there is significant survival advantage, and which I, in my practice, is using. Because if we remember the curve previously, patients with activated B cell type have a 2-year progression-free survival of only 24%. If you look at PolarX subgroup analysis, patients who receive Pola-R-CHP had a significantly better progression-free survival as compared to R-CHOP alone. However, this difference was not significant if your patient is GCB type or unclassifiable type. And if you look at progression-free survival of ABC and GCB type who have received Pola-R-CHP, it is quite comparable. So addition of anti-CD79B to your non-GCB type actually seems to reduce the poor prognostic advantage that patients of ABC type have upfront. Another type in which the subgroup analysis showed that patients, so dark zone signature is basically gene expression profile, which actually identifies certain signature which are actually surrogate for presence of double hit or triple hit lymphoma. So you can actually just consider that we are talking about that. So patients who had dark zone signature positivity, that means those who were c-MYC mutated. So these patients also seem to have a better survival probability if we are using Pola-R-CHP as compared to R-CHOP. So this is the second subgroup. And the third subgroup is in elderly patients, patients more than 70 years of age. So patients who are more than 70 years of age, the progression-free survival seems to be better if polatuzumab is added. And recently, in our last HEMONC meeting, we actually presented 3 cases. All of them were more than 70 years of age. All of them were treated with polatuzumab vedotin upfront, and we were able to complete 6 cycles in all of them, and all of them actually went into a complete metabolic response. So one was 75, one was 79, and other was around 77 years of age, all females. The safety profile of both the arms are comparable. So there is superior progression-free survival, but I think in Pakistan, we should select different subgroups in which we need to use this upfront. What I'll do that I'll choose a non-GCB histology in elderly patients, and if I have got a c-MYC positivity, it is a double hit lymphoma, but I'm not able to give them intensive treatment upfront, which otherwise double hit lymphoma patients would require in the form of either hyper-CVAD or dose-adjusted EPOCH-R. So with addition of anti-CD79B, this opened the gates for a number of trials in upfront. So if we look at these trials, all of them are trials which are currently ongoing upfront, in which the backbone is now again R-CHOP with addition of novel antibodies. So one of them is glofitamab. So glofitamab is a bispecific antibody, and it is unique because it has got two CD20 binding domain and one CD3 domain. So it is a bispecific antibody with two CD20 domains and one CD3 domain. And this data, although again, as we have received polatuzumab and the prices are likely to reduce further, maybe we do see glofitamab in coming days, but the data seem, although it is phase 1b, seems very encouraging. So if we just keep our previous survival curves in mind, and we see that the comparison is glofitamab R-CHOP plus glofitamab pola R-CHP. So in both the arms, addition of glofitamab has improved progression-free survival. So the progression-free survival in R-CHOP arm has also improved, and in Pola R-CHP has also improved. But if you add two different type of monoclonal antibody, one is monoclonal antibody, antibody-drug conjugate, and other is bispecific. So if you add glofitamab with polatuzumab, the progression-free survival seems to be highest, and it is approaching as high as 90%, which has never been, although it is phase 1b trial, the data is matured, but the signals which we see from this trial is that if you add glofitamab upfront, the outcomes seem to be much better. Another important trial which we can actually use, and we are using it at our center, is actually Smart Start trial. So it was initially a phase B trial which was published in 2019, and then later in 2023 its phase 3 trial was published. So it is basically RLI CHOP versus R-CHOP. So what is being done, that the patients are given initially 2 cycles of RLI, that is rituximab, lenalidomide, ibrutinib. You give them 2 cycles of RLI, you improve them functionally, you reduce your disease burden, and then you add CHOP in that. So 2 cycles of RLI followed by RLI CHOP. And again, this trial had just focused on non-GCB, because on the basis of phase 1b trial, so non-GCB cohort was the one that was better. And if you look at the results, so these are actually phase 3 results, which were published by Western et al. In 2023. The 2-year progression-free survival is 91.3%, and 2-year overall survival is around 96.6%. So it is lenalidomide 25 mg daily for 10 days, and ibrutinib 420 mg daily. So this is again a very doable regimen in our patients, especially those who are otherwise younger and fitter, but their clinical condition does not allow us to start with intensive treatment upfront. So to reduce disease burden to get into remission. So for the past 20 years, R-CHOP had been the standard of care for first-line DLBCL. Newer treatments have failed to improve outcomes versus R-CHOP. So POLARX was the first trial that we have seen. So a number of therapies are currently under investigation for first-line DLBCL, including bispecific antibodies. So I'm deliberately stopping my talk, and I am not moving to second-line and relapse setting because of time constraints, and I'll not be talking about CAR-T. So if there are any questions or comments, or we can move forward to next session. So we have to give 6 cycles of polatuzumab. So it is a finite number of cycles. So what we saw in our patients, so we have used polatuzumab upfront. We have used polatuzumab to get the patient into remission for transplant in combination with rice, so pola rice. And we have used polatuzumab with bendamustine rituximab in both transplant eligible and ineligible patient. Although we know that pola BR is approved only for transplant ineligible patients. But there are subset of patients in our setup, we do not have a clinical trial available, who will be refractory to R-CHOP, who will be refractory to RIs, and they are otherwise younger patients, who get them into remission, pola BR, and we have not seen bendamustine interfering much with stem cell collection in those patients. The only contraindication of bendamustine would have been if the patient is to go for CAR-T, but definitely that is the subgroup which we are not looking at right now.
So, Pola BR has been used for bridging for patients for CAR-T, and apparently the data shows that bendamustine does not reduce mobilization or does not have any problems if patient needs to go to the CAR-T. So that's new information for me.
I have a question, Rahil. It might sound stupid, but it is bispecific antibody glofitamab, which attaches with CD3 and CD20. Then why do we require R along with glofitamab, R-CHOP? Why do we require rituximab along with that?
Because the target antigen is different. So it would be binding only on anti-CD20, and bispecific would actually, it is a bispecific T-cell engager. So it will cause CD3 activation and will cause cell lysis.
So,
So both of them have seem to have synergistic effect.
effect. Like Pola, when we use Pola, it is R-CHOP with Pola. Thank you.
No, ma'am, they are different actually. So gray zone lymphomas are those lymphoma which are histologically not classifiable. And this is dark zone signaturing is on the basis of signature pattern which we see on gene expression profile. Thank you very much, ma'am.